I would now like to request Professor Chirantan Chatterjee, who's from Indian Institute of Ahmedabad, who's also our co-investigator at IHOPE, to introduce the next speaker. Professor Chirantan.
Yeah, thank you so much. I am logging in right now from the University of Sussex, where I've recently moved, and I still maintain a visiting affiliation at IIM Ahmedabad and with the Stanford University's Hoover Institution. Today we have Manoj Mohanan, who is a professor at the Sanford School of Public Policy in Duke University. Manoj is a rare breed in the sense that he's a doctor who has converted himself to an economist, and I really have great respect for his work, not just because he has published some awesome papers, and one of the recent ones he's going to discuss today, but he has been doing this work even before the pandemic. He has papers on the telemedicine effects on population health. He has papers on how you can tease out causally the relationship between health and wealth. You should look up his website. And recently he has also been very, very instrumental in seroprevalence studies during the COVID times across India, also leading a project on Cohesive India. So over to you, Manoj, and maybe you can take it from there. This is like Femina Miss India, but
I know. I feel like I'm in some beauty pageant or something. Thank you so much, Chirantan, for that introduction, and Dr. Rao, Dr. Raja, and everyone who is associated with IHOPE. Thank you for having me here. What I wanted to take this opportunity first to tell you is I'm super excited about the effort you're starting. We definitely do need institutions such as the one you're now creating in India that can all create opportunities for training and developing clinical scientists. A lot of the research that I see happening in clinical medicine, but in particular, often brings in economics as sort of an afterthought into it. And when I was training in medicine, this is about 25 years ago, I realized I was better suited to be an economist than a doctor. So I kind of made the shift all the way over. My objective today is not to try and convince all of you wonderful people to ditch the wonderful shores of medicine as I did, but instead to tell you how so much of the work that you do, even in medicine, even if you do not leave, has aspects of economics in there. So what I'm going to talk about today is related to some of the work we've been doing on performance incentives and the structure of contracts. So this is very much sort of based in applied contract theory. Overview, I'll start with a brief overview of incentives and pay for performance in health. I know this was supposed to be a keynote speech. I'm very much an empiricist, so I have to sort of ground any of my comments on evidence and first convince you that that's where that evidence comes from. So I'll tell you a little bit about our own work in this space in India that we've been doing for almost 10 years now. It'll be based on these two papers, one which is forthcoming next month in the American Economics Journal, Applied Econ, which will be coming next month. And the other one is a paper that was an offshoot that was published in the AER and Papers and Proceedings. So it's not the real AER, it's the conference version of that. I say that because economists make a big distinction between the real AER and the conference one. So I don't want to overclaim. But so these two papers will help us think through what we know about the role of incentives and the motivation to provide better care among healthcare providers. Both of these projects, I should give a big shout out to my co-authors, Grant Miller, Yulia Truskinovsky, Marcos Vera Hernandez, as well as Catherine Donato, all fantastic co-authors of mine at various universities now around the world, helped think through this. And I hope I can leave at least a few minutes where we can have some reflections or questions and answers if you might have any. So with all of that planned, let me jump right in. Oh, wait, I had promised I will have my timer on. Sorry. Jumping right in. So I'll start with a quick primer on pay for performance. I know most of you have at least heard the term, but there is the key point I want to leave here with this slide with is that there are lots of strong opinions about this topic. A lot of my really conservative economists in particular have very strong opinions that incentives are everything that matter. A lot of my colleagues who come from other behavioral sciences often state that incentives will crowd out intrinsic motivation. The idea that doctors actually are inherently good people who want to do good work, and then you introduce financial incentives and you're muddying the water. And these two sort of opinions often clash. And so the question then is, where's the evidence? And do we have strong evidence that supports one or the other? This is where then we turn to theory. So a lot of what I will be telling you today about is based in contract theory, the simple idea that there is a principal and agent. And it's almost like any kind of setting you can think about. You want to build a wall and you know what wall you want to build. So you ask the bricklayer exactly how many bricks you want the layer to put in there, how much cement and how much time. Or you might tell the architect, just build me a big, beautiful wall, to paraphrase the former president of the United States, big, beautiful wall. So there are two ways to do it, right? So that's the evidence. So once you sort of think about all kinds of interactions being interactions between somebody who needs to get something done and some other person, in this case, the agent who is getting the job done, you can start thinking of applications of contract theory. But here's the question, before I go into some more details on the theory, the problem has been that while pay for performance has existed now for quite some time, and there are tons and tons of projects around the world that have been doing pay for performance, the evidence has been decidedly mixed. There are some projects that find large effects, some that find almost no effects, and then there are others that sort of mixed, in the sense, if you look very, very carefully on one particular aspect, you'll find it. So for example, let me give you the example of the Rwanda one. This is one of Paul Gertler's early papers on pay for performance, big experiment in Rwanda. And it had very large effects. But here's the thing, out of the 20 or so outcomes that were rewarded, only 8 of them have very large effects. If you had not looked at those 8 and if you had looked at others, you would probably get a very different picture, right? So this is the challenge with pay for performance, is this mixed results. And so my main point here is, let's not throw the baby out with the bathwater. We still don't know why it is that sometimes it works, sometimes it doesn't. And it's what we need is more work to understand under what circumstances things work or not. Sadly, in health, this work is relatively thin. It's not that others haven't been working, but compared to, say, the work in education or teacher incentives, which has a huge literature, not just globally, but also in India. So my colleague Karthik Muralidharan and others have been doing some awesome work in this space. In health, less so. So I really hope that at the end of this session, a number of you who are working on research-related topics related to economics in particular will start thinking more about this topic, and I'm happy to take more questions. So let me give you the motivation. As I told you, when you want to build a big, beautiful wall, you could probably reward the inputs. That is, you could tell the bricklayer, these are the number of payments I will make to you based on how many bricks you lay in, how much cement you do, and how much time you work on. Or I could tell you, I will give you X amount of a reward if you have the best beautiful wall, right? This is essentially, in a nutshell, rewarding inputs or outputs. But the problem is the following. Output-based contracts fundamentally have to assume that the agents, the people who are doing the stuff, actually know the underlying production function, and then they can find optimal combination of inputs in their own context. So doctors, if I go to the doctor and tell the doctor, look, I want you to take out my appendix, I probably do not want to tell her, I want you to use 7 sutures and make an incision that's only about this thick and use these many pints of blood, or so on and so forth. The assumption is that the agent, the doctor in this case, knows the production function and knows what works best in her own setting. The problem is when we have low-skilled workers, and if these inputs are observable and verifiable, that is, now instead I'm just asking someone to come and clean my office after I've made it messy, I could possibly tell the cleaning janitorial staff that I would like you to spend 15 minutes and pick up these specific things and be done, right? So the empirical question here is, do agents perform better when they are able to innovate or not? And as I told you, the evidence is kind of thin. But there is also a reason for doing this, is because we know that in lower and middle income countries, there is a large no-do gap. That is, a lot of research, including some of my own work in the past, we've found that, yes, we have few providers, but even among those few providers, we find very systematic evidence of low effort. That is, if you went and asked healthcare providers what they would do, you'll get the full long list, which is like in a medical exam. If you observe what's actually happening in the clinic, and we do this with standardized patients, where we send in unannounced standardized patients, what we find is that there's actually a big gap between what is reported, what the provider can do with the available infrastructure, versus what happens. And all of this points towards the role for incentives. Right? So key idea here is this, is that if I'm an agent, right, if I'm the person who's building the wall, then I can produce these outcomes using my effort. So in this case, you can ignore all of unnecessary Greek terminology. The key thing here is there is something called a theta we use here. The theta is a productivity modifier, right? What it basically tells me is, let's say Chirantan and I are both building a wall, right? But Chirantan's wall is in the UK and my wall is in the US, where it's in the southern US, where it's extremely humid. So I would know something about the productivity of cement in holding my wall really, really well and being strong, versus Chirantan knowing something about how cement works better in the UK based on its weather. Now, if you come to both Chirantan and me and tell us exactly what kind of cement to use, you will have to know a lot about that data, the productivity shifter that tells us how productive this input is. The same thing happens in health. Right? So I see Dr. Ashish Satal from Mahan is here. He works in settings where I don't honestly know how healthcare works. Right? So if I have to write an input contract with Dr. Satal's organization, I have to know exactly how that productivity shifter is. If not, then input contracts are going to be very difficult. I cannot write a contract as a government with Dr. Satal's organization because I wouldn't know how inputs are going to be used. Right? So in that setting, I would probably want to tell Dr. Satal's organization, I would love for you to do X being some health outcome, and let him innovate. Of course. The problem, however, is it depends on Dr. Satal's organization having that level of skills, the human capital, to be able to understand the problem, to understand the nature of the risk involved in this contract, and then innovate on all of this stuff, right? So that's an underlying testable hypothesis that we can take to the field, is performance under incentive contracts is not simply a matter of saying, I got the contract and here's how I responded, but it's a function of the underlying provider skills and a whole bunch of other provider characteristics that I'll tell you about in a second. So very quickly, I'll run through these papers. It will be on light speed. So apologies, this is like about 9 years of work I'm summarizing in 3 minutes. So it'll be a whirlwind, so hold on. So this paper is called The Different Strokes of Different Folks. And the key idea is we are trying to understand providers with varying levels of skills and how they respond. The policy context here is, in India, there have been contracts where governments have written contracts with maternal health providers to increase the quantity of services. Right? So think about programs like Chiranjeevi in Gujarat or the Thai Bhagya Yojana in Karnataka, where the government gives money to healthcare providers to deliver X number of babies. So what you get is more deliveries. Do you necessarily increase outcomes among the population? Kind of, not really. We don't see much evidence for that. Right? So in the policy context, this started because in 2009-10, when we were negotiating with a number of governments, there was appetite to think of this following question, is if we are going to create reward systems for hospitals, then rather than rewarding them on volume, is there room to reward performance? This is still a very relevant policy question. You know that Niti Aayog, for example, has been trying to think about hospital contracting programs. And so there is the possibility of including these types of contracts as well. So what we did was this very large field experiment in Karnataka. We went to all the rural areas of Karnataka and found as many doctors as we could who work in rural settings and have their own private clinics, because remember, this was about doctors being contracted by the government, the private sector. And then within these sample of doctors, we randomized them into 3 types of performance contracts. One, the control group, which got all the information about Government of India and WHO's best practices guidelines. one of the treatment arms where we told them, doc, you're the expert. I'm not going to tell you how to do stuff. You know how to do things. All we would like to see is make sure that there are fewer cases of postpartum hemorrhage, sepsis, preeclampsia, and neonatal mortality. As doctors, you know very well that doctors might not be able to change the rates of preeclampsia, but we wanted to include that so that we don't create something called multitasking. That is, people don't ignore that problem. And the input-based contracts, where we told the doctors that, look, we will interview patients at random. We'll go to every single patient who's come around in your clinic in the next year, and we'll ask them what you did. And based on adherence to inputs, which is the WHO guidelines about, did you check the fetal heart rate? Did you check for all kinds of problems? How often did you check the progress of the delivery, and so on and so forth? Based on those adherence to inputs, we'll give you rewards as well. Right? And then we gave them a whole bunch of money along the way when we went and bothered them for surveys, so that doctors knew we were serious. So every time we walked into their clinic, we'd give them 2,500 rupees, so they know that there is large amount of money at the end. If you're already thinking, the rewards were fairly substantial. If the doctor had managed to accomplish what we thought was a reasonable amount of improvement, they could make about 1.5 lakh rupees a year on incentives alone. So it's not trivial. We have about 135 providers in these 3 arms that were in the 3 groups. Generally slightly more female. That makes sense in the rural context. 5 of them and they're not fly-by-night operators. They're about 47 years old, 20 years of experience and stuff. Great. So we collected a ton of data and the one important thing is this is not retrospective standard cross-section. Instead, we were keeping a tab of how many pregnant women are in each of these areas across the state, and then follow them up within a 2-week interval after the delivery to avoid recall problems. And in addition to that, we did a whole bunch of provider surveys and stuff. Happy to tell you later more about that. Simple analysis is basically, it's just an OLS. Economists love OLS to estimate the effect of treatment, but we do a whole bunch of robustness in there with the clustering as well as multiple hypothesis testing and stuff. So key finding, what we find is that the postpartum hemorrhage rates, which was one of the main things, reduces by about 21% in both of the treatment arms, inputs as well as outcomes, right? And one possibility why we see improvements on PPH but not others is that maybe it's more amenable to improvement. Maybe it's harder to change rates of preeclampsia, we know, but also sepsis because there's so much overprescription of antibiotics and so on and so forth. We then looked into all kinds of possible reasons why that might be happening with the inputs. Main story here is that we don't find any effects on the input measures, indexes, when we look at them as an index measure. Main possibility is that as a doctor who's taking care of a pregnant mother, you do 50,000 things. And when we sort of take an index measure, because no 2 patients are alike, you might not find systematic improvements in sort of one family of outcomes, because for every single patient, you might be doing a different thing. You might be solving a different problem. So to try and solve that issue, we looked at specific things that might be related to the PPH, whether or not the hospitals in the treatment area, treatment arms, carried more oxytocic drugs, or whether we saw reductions in placenta manual removal of placenta, because arguably this is a complication. If you're doing your job well, you should not have those many instances of complications. Great. So it seems like something's happening. We also find that rewarding outputs is actually very expensive, but this could simply be because of the weird structure of the contract we impose. So I don't want to make much of a to-do about this. You can overlook this part. The key part, remember I told you the whole part of the reason for this study was to try and understand heterogeneity. So our conceptual framework suggests that providers who are highly capable, high levels of training could do things differently. So we looked at 2 groups of providers. Providers who have an MD or a DGO type of training in OBGYN versus who are MBBS providers only working in these areas. And we tried to see if there's any differences. And the key takeaway here is, remember I showed you that 7-8 percentage point improvement? Almost all of that in the output group is driven by the MBBS plus providers, the providers who are highly trained, right? So just to reiterate the finding here, what it says is, if I am a highly trained provider and you give me an output-based contract where I can innovate, you see an effect that's almost twice as large as if you came into my office and told me, Manoj, I want you to do these things. It's not that I don't improve, but that improvement is relatively small, and actually it's not statistically significant. You can see here, the standard errors are about the size of the effect itself. Right? That's a very important finding. Versus if I am an MBBS only provider, output incentives are not doing anything for me. Right? So then you might say, well, how do you know this is actually working? So when we were collecting all of this data from the providers, we also went in and asked them what they were doing. Are they implementing new strategies, right? And so what we did there is when we found out what strategies they were doing, are they training more of their staff? Are they buying new equipment? Are they introducing new processes? A lot of the MBBS plus providers, the MD, DGO type of guys, as opposed to the MBBS providers, were starting to implement new things when they had the output contracts. With the input contracts, where we told them, we want you to see these 15 things that government of India tells you to do, not so much, right? So that was the main one. I'll skip this one in interest of time. And then this is the last slide. All of this is great, but do all doctors respond the same? Well, not really. So we took our lessons from the literature in psychology, where there's something called big 5 personality traits. And these big 5, among these big 5, there's 2 of them, conscientiousness and neuroticism, that are supposed to be very highly related to performance literature. And then a lot of this comes from psychology and management science as well. Economists are relatively new to this. So conscientiousness is about dependability, organizational skills, and perseverance. Now, you would think that these folks are already doing better, right? You would expect that people who are highly conscientious doctors are already running organizations that have better outcomes. And indeed, that's what we find. But what we also find is that when you introduce incentives for this highly conscientious doctors, you do find that the incentives are not as effective. Right? So think about Chirantan versus me. Chirantan is highly conscientious, and I'm not that much. I'm not dependable. I'm not very perseverant. I'm giving up stuff quickly. I give up my motivation to incentivize me or drive me to do better. But Chirantan, who already starting from a higher level, not so much. It doesn't have that much of an effect for him, right? So this is where the psychologist's argument about potential crowding might actually be happening in a smaller subgroup. It might be there. And the second one is about neuroticism, is emotional stability. So there is a whole literature in high-stakes sports like Olympic sports, where athletes who show high levels of neuroticism, when they see these high-stakes contests, they freeze. Right? This happens. Like really smart student, you put them up on the stage and say, now you go ahead and defend your idea on stage. They might have stage fright or choking that happens under these high-stakes settings. So what we find here is also a similar thing, that providers who reported high levels of neuroticism in our psychological testing also do not respond very well to incentives. All of this is to say that when we think about introducing incentives, does it work? Surprisingly, what we find is that both input and output contracts can achieve comparable gains, but the problem is it doesn't work the same for everyone. It's not a cookie cutter approach. Right? This is one thing that I find a little frustrating in the literature, is often the question is, does it work? And the answer is not, does it work? The answer is, it works differently for different people. It works differently for high-skilled workers, where output contracts might be more successful and input contracts might be more successful for low-skilled workers. The good news, it looks like despite lack of previous evidence on this specific question, a lot of governments around the world were already using input-based contracts for their low-skilled workers. So when you think about the kind of performance rewards that governments use for, say, ASHA workers, it often is of the nature, you do these 5 things and I'll give you a reward. It doesn't say, make mothers healthy, do whatever you have to do and I'll give you a reward. Policymakers were already doing what our research finds is the right way to do this, which is good. So for future research, we probably want to dig deeper into what sort of mechanisms of the contract help sustain this equilibrium going forward, or we can learn more things around observability, relaxing the verifiability, and so on. So thank you very much.
Thanks a lot, Manoj. Great thoughts. Back to Arna's questions on the chat window, please.
Thank you, Professor Mohanan, for your insights.